ahead and get started. Traditionally, we review the Quad AI meeting that we all attended, and we've got like 4 or 5 days of sessions to review in 1 hour. The 4 of us are going to be presenters today, myself, and Jake, and Dan, and Dave Naeem. So we'll all try and be fast about it. Other people in the room attended, so hopefully chime in with any comments along the way. All of on the paper handout, they're all together, but they're not in the order in which we're going to present. So the ones that I'm going to present quickly at the beginning here actually start on page 7. The paper handout. So on the first slide, I just made some general comments here. For those who are new to this field, the meeting gets shorter each year. It used to go until Wednesday noon, and then 1 or 2 years ago they took away Wednesday sessions because no one stayed. This year they took away Tuesday sessions, so they ended on Monday. But what they really did was front load the meeting, so it had the same amount of content. Thursday was a very busy day. It didn't used to be as busy. Friday as well had many sessions overlapping of interest. You could only go to one. The plenary and the keynote sessions, I just quickly outlined the main themes of each of them. On Friday, origins of childhood asthma, work in Wisconsin on the importance of rhinovirus, especially rhinovirus type C. Pretty much all this work coming out of Lemansky and the group. Nothing new, stuff that they've published for many years, particularly showing that this subclass of rhinovirus C is the most pathogenic and the most severe, and the risk of kids who develop it early in life going on to have persistent asthma. Work on microbiome, again, mostly from Europe. And one thing that was new to me is if you have 17q, that's a 21 as a gene, greater likelihood of interacting with important organisms in the microbiome is being protective against developing of atopy. And then a talk on epigenetics. Saturday's main theme was interesting. Tom Platts-Mills gave a very nice historical talk on 50 years of IgE, biology and knowledge. Nothing that we didn't know, but one of the most straight, I said to him afterwards, one of the most sort of straight, normal talks he's ever given. He didn't joke around. He didn't say unusual things. So I complimented him on that. Saturday, past, present, future of asthma. Really, this was what's the guy's name who presented this talk from Southampton? Holgate. A nice talk, and he ended it with all the new complex stuff about computer digitization of where we're going in medicine, of figuring out phenotypes of disease by very complex computer analysis that I don't for a minute understand, but clearly that's where he was going with that. Sunday's session, prevention, modification of atopic disease. Clearly the big newsworthy studies that Dan is going to present in just a minute were Gideon Lack a year later from the LEAP study, now presenting what they call the LEAP-ON study, essentially 1 year after all the data on 5 years of feeding kids peanut from early birth, asking the question, if you take them off peanut, do they have tolerance? And Dan will go over that with us. I didn't see it, but it's probably in the New York Times the next day. It was released by the New England Journal electronically like an hour after he finished his presentation. It hit my iPhone. Eczema, work about the importance of barrier function, the Th2 cytokine, reduced tight junctions, and something I have always wondered about, what makes you itch in eczema, because antihistamines are not particularly effective. Apparently IL-31 is important. I don't know how we counteract IL-31, but interesting. And then Monday, the guy gave an interesting talk about urinary metabolites as a bioassay for asthma. And the main point of this was that little kids, they can't do any of the tests, and so, diagnosing asthma in little kids, for me as an internist, is like veterinary medicine. You don't know anything. So he didn't tell us what the metabolites were, but a panel of metabolites in urine samples, at least by computer analysis, was very good at separating normal kids, asthmatic exacerbations, and COPD. Not sort of ready for prime time, but an interesting thing that they're in the process of developing. Then to talk about birth cohorts and to talk about eosinophilic esophagitis. Interestingly, there was a whole session, a whole day on eosinophilic esophagitis back on the Thursday, and I don't really know how they made a whole day out of it, because from the two sessions I went to on EOE, there was nothing new whatsoever in skin testing or patch testing or diet. Anyway, just one particular session. I know Dan went to Steve Durham's presentation of this. I went when Bill Kwok presented it. So this was an interesting study to me, and the reason I went to this session is I've always been fascinated looking for a biomarker to tell people if they're tolerant from immunotherapy and who's you can stop and they're going to successfully stay tolerant, and who's going to relapse after 4 or 5 years of immunotherapy, because it's really just a crapshoot. You don't really know. I usually tell people I think about 30% of them are going to not be tolerant and they're going to relapse. So that's what this session was about. And this particular study was sponsored by the ITN, the Immune Tolerance Network. Steve Durham was the main presenter, and they actually presented it in 2 different forums. Steve presented it, Dan went to that session. Bill Kwok presented the immunologic data in another session. Steve was nice enough to lend me some of the slides. The other thing that was interesting about this study, to my knowledge, is the first head-to-head study of subcutaneous and sublingual immunotherapy done in parallel with a placebo group. So that's what the study design here is showing. These are just the demographics of the different groups, which essentially say that the groups were well matched. This is a very complex slide, basically showing the subcutaneous group on the left, the split group in the center, and the placebo. And these are symptom scores. What they did in this study was enroll people and then had active treatment for 2 years and then took them off in the 3rd year. And they followed clinical and immunologic parameters. And to tell you the punchline, actually, because the data are complex, subcutaneous is clearly more effective than sublingual immunotherapy. It was clinically effective in 1 year, while sublingual immunotherapy didn't really hit any statistical data points of efficacy until 2 years. And then when both of them were stopped, all of the benefits, immunologic and clinical, all reverted back. So the bottom line of the study is, to me, that was interesting, is subcutaneous, as we've all, I think, thought, is clearly the more effective form of treatment with greater statistical data and onset coming on earlier, and that 2 years of immunotherapy is not enough to make anybody tolerant. So that was the punchline. What I was looking for was if they had developed a bioassay that was useful in telling people when they've had enough immunotherapy. I asked Steve, are they going to carry this out for a 3rd and a 4th year to see if anything was persistent? He said, no, they don't have enough money. This was an expensive study.
Did they do sublingual year-round or just co-seasonal?
I honestly don't know.
It was year-round.
It was year-round. The other thing they did, and maybe Dan, since you went to the clinical talk on this was a double-blind, double-dummy study.
Yeah.
So technically, you just realize how hard that is. So people on placebo, I presume, were getting tablets and getting injections and thought it was efficacious, even though it was all placebo therapy.
This was through Nasal Challenge. So they sprayed them with grass. This data, yeah. And so that's what TNSS is. It's the nasal symptom score that they get, and so they have to get a certain level. And so they figure out what the triggering dose is, and then they use that dose to base off of what the improvement that they get from the immunotherapy. So this is, they're very strict about this. This has to be done within like the day of the time points of it, 6 months to the day, 1 year to the day. So I was talking to the person who was in charge of this thing, and they said that they would be doing nasal challenges 10 hours, 12 hours a day to make sure they get all the time points, because they had to do it out of the season, and it was a really complicated study. This is all funded, actually, it was done in England, but it was funded by ITN and NIH. Ours.
Yeah. These are serologic changes looking at IgG4 and IgE, and particularly impressive to me is the IgG4 panel, the red line there being the increase in blocking IgG4 antibody in the subcutaneous group, placebo on the bottom, and statistically significant differences, much greater generation of blocking antibody in the subcutaneous group. These are markers, like the upper left-hand corner there is changes in innate T cells, and you can again see by all of these markers that the subcutaneous form of immunotherapy is the more effective. And just the conclusions from this, I left out a lot. There's a lot of data here, but significant decreases in the frequency of a lot of markers. Allergen-specific cells were more so in the subcutaneous group compared to placebo or in the slit group during the course of immunotherapy. Decrease in markers of immunotherapy in the slit group and the placebo group. Again, the same outcome, that more effective outcome in the subcutaneous group, and pretty much made that point. So the final outcome is both subcutaneous and sublingual suppressed allergen-induced nasal symptoms by year 2, but only subcutaneous did it by year 1. The effect, as I said here, of subcutaneous came on earlier and was greater, and the differences between the placebo and the active groups was insignificant and returned to baseline in just 1 year of taking people off. So it didn't really answer the question that I was interested in, what happens after the traditional 4 to 5 years with either of these forms of treatment. But it's the first study of its kind that at least supports my bias that sublingual immunotherapy is not as effective, as rapidly, or overall as what we've been doing for 50 years, subcutaneous immunotherapy, and that 2 years of either form of treatment is not enough to give you tolerance. Jake will go next, and then Dan will talk about really the blockbuster media studies, the LEAP-ON study about peanut, and the EAT study about desensitization or attempting to introduce foods early beyond peanut.
I'm going to kind of review some smaller studies that weren't mainstream stuff, but stuff that is just kind of clinically relevant to me this year. It potentially makes my life a little bit easier. First, kind of going over cefazolin use in patients who have a penicillin allergy in the perioperative setting, whether it's safe or not. Using omalizumab in asthmatics outside of the indication window of a baseline IgE and how it was monitored. And then looking at some of the scripts data, trying to predict who will be a severe reactor in patients who are undergoing aspirin desensitization for AERD. This is at the California Science Center at the Foundation dinner. This is the Endeavor Space Shuttle, and I just wanted to thank NAC and all the supporters who helped us go to that.
That thing is really big.
Yeah.
Amazing. You don't realize how big it is until you're standing underneath it.
So for the study regarding ceftazoline and whether it's safe to use it in a perioperative setting with a history of penicillin allergy, it was a retrospective study done at Rochester General Hospital. And what these folks did is they looked back at several patients, 844, that had listed adverse reactions to ceftazoline in the perioperative setting. And then from those 844 patients, they found 89 of them had a listed penicillin allergy. The allergies that were listed included rash, hives, GI reactions, itching, hand swelling, blisters, flushing, and some other just not charted histories. And then they compared those patients to the grand scheme of patients and put them into categories of how these patients had listed adverse reactions. Those listed adverse reactions they put there were GI symptoms, shortness of breath, neurologic issues, itching, headache, rash, and other. And then they compared the two to see if there was anything that was more common in the penicillin history. Of note, there was no clear anaphylactic reactions recorded. And of all the symptoms that were charted for having adverse reactions, there was no significant difference between the two groups. They did note that if you go back, that of the penicillin historical reactions at the very bottom there's nothing that's blatantly concerning for hives, so that they do, even though they didn't see a significant difference, they probably are biased in their patient population that none of these perioperative patients are given ceftazoline if their penicillin allergy was clear anaphylaxis. So from that, they've made a general conclusion that likely using ceftazoline in somebody who has a listed penicillin allergy that's moderate to mild is probably pretty safe and overall not that concerning.
So I'm confused. The 844 they selected had gotten ceftazoline perioperatively and were selected because they had a reaction to it?
Yeah, so it was retrospective, and they essentially just pulled from their EMR people who had been given ceftazoline in the perioperative setting, but then had a listed adverse reaction to it. From that,
From the perioperative.
they were so people who had a reaction attributed to ceftazoline in the perioperative setting, so some kind of adverse drug reaction, and then they from there looked at that subset of patients who also had a penicillin allergy, tried to compare the two groups to see if there's any difference. They didn't find any significant difference.
Did skin test anybody to see if any of the history was valid?
They did not. Retrospective. So.
This was presented as what, like oral abstract or?
This is just a very interesting poster that I thought could potentially help things out a little bit. Moving forward, this next study, I think several physicians use omalizumab not in the defined treatment criteria, that being greater than having a baseline serum IgE greater than 1,500 international units per milliliter, where it's designated 30 to that range, just under 1,500 in asthmatics. And then so this study is also retrospective out of Texas, and it's looking at and comparing patients who had a baseline serum IgE greater than 1,500 versus the lower range that are in the treatment indications, and monitoring with a couple different modalities. Essentially, did these patients fare as well as the lower baseline IgE patients? Just to kind of confirm what other people are using Xolair in this higher baseline IgE population. to be included in their patient study, they had to have been on omalizumab for at least 1 year and followed 1 year prior to that and 1 year after treatment. They grouped patients based on baseline IgE, so group 3 being the patients with greater than 1,500, and then group 2, group 1 and 2 with the lower, descending lower values of a baseline IgE, both in treatment indication for omalizumab and allergic asthmatics. The way they assessed for response in these patients was with essentially 3 modules, but really 2. The first module was using a Getty score, Global Evaluation of Treatment Effectiveness, essentially kind of a physician's personal assessment of how the patient was responding to omalizumab. Versus the second module, they had to meet 3 of 6 criteria, essentially 50% reduction in asthmatic exacerbations, steroid burst treatments, ER hospitalizations, or improvement in the FEV1 or a improved ACT score by greater than 3. And then module 3 is essentially just saying what they're attributing true responders to the treatment are somebody who met both the first module and the second module, so clinical improvement and then physician assessment. So group 3 is the greater than 1,500 IgE, and group 1 being the lower baseline IgE. Module 1 is essentially the physician assessments, and they're, from looking at that, they are saying that it's not really going for me, but they're saying that the physicians felt that at least compared to the lower baseline IgE, people were doing better, if not a little bit better. Well, the higher IgE people did just as well as the lower baseline IgE. And then based on more clinical parameters, it also showed that it was doing just as well. And if you combine those for overall kind of what they appreciated as true responders, it seemed to be pretty even across the board. So overall, of what they kind of said true responders, there was 64.3% of patients were true responders to omalizumab. There was no kind of statistical difference in what they attributed as or called true responders with people with a baseline IgE greater than 1,500 international units compared to the lower population, which I think most providers treat with omalizumab at that IgE, but it's just not in the original kind of treatment criteria. It's just nice to have a kind of study that says that. And then it was just a side note that it was interesting that of the way they used the modules, the first module was more using a Getty score, which is more physician's assessment, versus the module 2 was more clinical data that the physicians were kind of saying people were responding better than just the going off of harder clinical data.
For group 3, was everybody just at the highest dose?
Yeah, did they push the dose above recommended levels? Or?
Right. So the recommended levels being a baseline IgE of 30 to 1,500 international units.
No, the amount of Xolair they gave.
They go every 2 weeks on the maximum dose. Is that what they did?
375 Q2.
It didn't specify.
And the other, they probably didn't have access to this to measure the free IgE. Because years ago when this product was first released, Jerry will probably remember, I think, it was said that you had to get the true IgE under 10 to be effective, but none of us have ever had the assay. So once you put people on Xolair, you can't measure their IgE. And it's never been a commercially available assay, so you just sort of by the seat of your pants giving the dose based on the original studies.
And in the multi-food study, we pushed the Xolair all the way up to 2,000 baseline IgE. and I see no difference between the people with 2,000 versus the 150s in terms of their response to Xolair as a protective against anaphylaxis.
I mean, it definitely fits clinical observation. We have a lot of people. I have a guy with bronchopulmonary aspergillosis. His IgE is like 15,000, who seems to do well on Xolair. How we got it approved, I don't know.
Is he better with Xolair at the 15,000?
Yeah.
Yeah.
Well, there's a lot of evidence for its use in ABPA, and I have some who respond to it and some who don't. I have one who's now like 6 months into treatment, finally starting to respond. You wonder if you could have pushed the dose higher, if that would have made a difference or not. I don't know, because they have really high IgEs.
Last one to review here. As you know, UW is doing a lot of aspirin desensitizations now for AERD patients. Scripps was one of the kind of leaders in the field. So they kind of presented their data as to what, after they reviewed all their patients that they had done from 2009 to 2015, what were the positive predictors of people who are going to have a severe reaction to this treatment. So from that time period, they were able to identify 275 patients. Of those patients, they included 167 for this review. Of the patients that reacted, most reacted to the nasal ketorolac, 88% of patients, and 37.7% of patients reacted to the oral aspirin. The provoking doses are listed there. They broke it down into 3 reactions: severe GI reactions and isolated nasal-ocular reactions. So let's start with that one. People that had that type of reaction, oral aspirin induced it in 27% of the patients, and nasal ketorolac, 55% of patients who reacted. So it was more common with the nasal spray, which would make sense. And they also noted that with ketorolac, that was more likely to have patients experience a significant drop in their nasal inspiratory flow. Neither of these, there was no difference between the oral aspirin and the nasal ketorolac in patients who have this type of reaction, as far as a difference in any kind of FEV1 decline in these reactors. They also had a very small portion of their patient population that had gastrointestinal reactions, 17. Of those 17 patients, 10 of them had this response to the nasal ketorolac, 6 to aspirin orally, and 1 had symptoms in response to both treatments. Retrospectively, 8 of the 17 patients, which is 47% of those patients, reported that they had had a previous GI reaction to an aspirin or an NSAID. And then one of the most important kind of reactions is severe reactions, which the group defined as anyone who required IM epinephrine, someone having an FEV1 drop greater than or equal to 30%, and or requiring greater than 3 or greater bronchodilator treatments. Of those patients, all the people that had the severe reactions, they did note they were able to successfully carry through with their desensitization in an outpatient setting. The one finding that they were able to find that was somewhat predictive of people having a severe reaction was actually a SNOT-22 score. The people who had the severe reactions had a higher score on that. That's a questionnaire if you're not familiar with it, like I wasn't. It's completely subjective, and the patient fills it out. I have actually a copy after a slide here to show you what it is. But it just essentially is patients rating their own symptom score over 22 questions. What is interesting is they found there was no difference in patients' baseline FEV1, as well as the ACT score, peak nasal inspiratory flow. But the FEV1, there was no difference in baseline FEV1 between severe reactors and non-severe reactors, which I think is kind of what they really wanted to know 13.8% of their 167 patients they reviewed had severe reactions. Again, the SNOT-22 score was the only one that was associated as kind of having some predictive value. There had been previous study that suggested an FEV1 less than 80% would be predictive of potentially having a more severe reaction to this challenge, but their data wasn't able to confirm that finding. And then as far as the GI reactions, they didn't have any reliable means of predicting who would have a GI reaction other than just asking them historically if they had one. And so with the SNOT-22 score being the only thing that they found that had some predictive value, this is just kind of a copy of what that is. So it's just all these symptoms, and then the patient rates their score, and then you total them up and see what their score was. And the severe reactors had a score around 40s versus non-severe was around 20s.
How are you doing this? The challenges here. Do you use the nasal ketorolac part of it? Yeah.
Yeah, we do the exact same
Same
protocols.
protocols. How many have you done?
I don't know, 40, 50?
Yeah, quite a few.
And then you keep everybody on 650 BID, or
You titrate it. 650 BID is what you start with. The ones that do well at 9 months to a year, you try and wean them down to 325 twice a day. But most people stay on the 650 twice a day, and it's really well tolerated, actually.
Hey, was that a poster or a presentation?
That was a poster.
Did they, because you'd think, I mean, the higher SNOT score may correlate with not, med non-compliance. Did they, we talked to them, we're going to start doing this score as well. But did they talk about it in the poster at all? Did they look at that had to do with medication use or
Wasn't
anything?
yes, no.
But the question would be, should you, if somebody has a really high score on the day, should you just wait and treat them more, or put them on prednisone, or wait for a better period or whatever, and then desensitize them, if you want to avoid a severe pulmonary reaction?
It also didn't specify was the SNOT score on their intake day or the day of challenge.
Right? 'Cause they're doing it at both, I think. I don't know. You should ask them that. I mean, that would be an interesting thing for us to address with them. Is, we've talked about how do you deal with the GI reactors, and we're coming up with a plan for that. But we're going to start tracking this score, and we'd probably want to track medication use at the same time. So I definitely had a lot of patients who come in and they say they're on all their meds, and then it turns out they're not on their Singular, or they haven't taken it in a week or whatever. So I'd wonder if that's what's driving this.
What is the main GI symptom?
I don't have enough experience to know what.
They basically just get intractable nausea, vomiting, and feel really bad. And it's we've had a few. It's not a pleasant day for anybody.
When does that happen, during the ketorolac stage or late?
It can happen during either. We had one who it occurred during ketorolac. I mean, I kind of felt he was probably drinking the ketorolac, but who knows? But it can happen with either. I've also had it with the aspirin dose.
in spite of these data, do you reject anybody here if their FEV1 is too low, that you think it's a dangerous challenge, if they're 30, 40%?
We haven't. I have a guy who just came in who has an FEV1 just above a liter, and we're debating whether or not to do it. I kind of left it up to him, but we haven't so far rejected anybody. I know at Scripps they don't really like to go below a liter, but they've gone down to a liter.
All right, Dan. So, as I mentioned before, clearly the big newsworthy study and the continuation out of England of peanut and food challenge work. One called the Leap On study and the other called the Eat study. People get more and more clever with the abbreviation.
So I have a few disclosures on all these different studies. So the Leap On study, which I think should actually be named the Off study since it was taken off, but neither here nor there. So an add-on study to the Leap would to compare peanut allergy prevalence between the peanut avoidant group versus the peanut consumptive group after 1 year of peanut avoidance. And the secondary point was to evaluate the sustained unresponses in the people in the group that consumed peanuts and post after 1 year of avoidance. This is my own photo from Gideon's talk. Up here, so LEAP started when these kids were between 3 to 11 months and then continued all the way up to 5 years of age. And the consumption group were eating 4 grams of peanuts a week, and the avoidance were not. And then at 5 till 6, they were avoiding it, and then we're checking at the 2 endpoints. So we're comparing 2 groups. So we're comparing the group that consumed versus the group that avoided, as well as the pre and post for the consumption group. So this is their protocol definitions for consumption. So they had to consume at least 3 grams of peanut per week in at least 50% of the weeks recorded, and consumption of at least 2 grams of peanut protein on at least once in both occasions. Avoidance was less than 0.2 grams of peanut protein on any occasion, 0.5 over a week. With Leap On, they understood that these kids had been growing up on peanuts, so they were a little bit flexible for it. So the avoidance was no more than 2 grams of peanut protein on 6 occasions over a period of 12 months, and no more 1 gram per peanut protein over 12 occasions over a 12-month period. And then cumulative, no more than 18 grams. So the per protocol adherence, so 80%, which is pretty darn good, met this criteria for peanut avoidance. As expected, the avoiders were very compliant with this, as opposed to the consumers, which are about 70%. So this was, just to review, this is the outcome from the original LEAP study. And we can see here, so they split up the cohorts between the skin prick negative, skin prick positive, and then this is, the gray bar is the avoiders, and the consumers, it's the green bars, and we can see that there's a significant difference in both the cohorts between the development of peanut allergy. So here's the LEAP On. So once again, we continue to see the same trend between the initial avoidance group versus the consumer group, right? With a significant difference between both the skin prick positive and the skin prick negative. And then if you compare, this is the per protocol, LEAP and LEAP On. So these are the people who really adhered well. So they ate exactly what they were supposed to eat. The previous studies were just the intention to treat. And we can see that the numbers are even more apparent here, where the total number of kids who, comparing the 2 groups of both cohorts, only 2.1% of the consumer group developed peanut allergy. So the benefits of early peanut introduction persisted after 12 months of cessation of peanut consumption. There was a non-significant increase in peanut allergy in the LEAP consumers after 12 months of avoidance. So this is comparing the pre and the post for the consumer group. So 3.6% of the consumer group had a peanut allergy. And remember, this was double-blind placebo-controlled, so these were real. So it's not just skin prick positive. These were real. And then 4.8% at 72 months of this consumer group was not statistically significant between the differences between the 2. So it was persistence. So both LEAP and LEAP On found that early introduction of peanut before 1 year of age in high-risk infants, so these were all examinous babies, induces unresponsive to peanut at age 5 that persists following 1 year. And his next question was, could this be expanded to the general population? And that was the next study, the EAT study.
And then there was one important thing I thought, though, in the immunologic data from that, which was the IgG subclass 4, if you assume that that's the blocking antibody, started to fall in that year off.
They did.
And the ratio between that and the IgE, suggesting that you might be losing your tolerance if you let it go that way longer.
It's interesting, but there was no statistical significance in the actual clinical presentation of it, which I've always had a question about that particular part of data. So each study is a randomized trial of introduction of allergenic foods to breastfed infants. And so this was comparing the recommendations of 2 styles of infant feeds. So with the traditional the World Health Organization REX was exclusive 100% breastfeeds for 6 months, followed by food introduction ad lib at the parent's discretion. So this is like thickened cereal, blended foods, and then kind of progressively progesterone. WHO has no specific restrictions in terms of peanut introduction or anything other introduction, apart from it must happen after 6 months. They did not include any formula-fed infants. This was just, they wanted to make it an easier site to control, so they just wanted to have exclusively breastfed infants. And then the early introduction was to introduce solid foods, blended solid foods, at 3 months of age, and in conjunction with breastfeeds. So here is, again, one of my pictures from the study. So the entire cohort is 1,303. So this is all comers here, so this is not high risk. Split off into the standard introduction group of similar numbers, 650, 650. And so this was all started at 3 months of age, and the outcome was at 36 months. And so the kids who got, at the end here, were skin prick tested, and then any skin prick tests that were positive, they underwent a double-blind placebo-controlled food challenge, and the ones that were positive were considered allergic, while the ones that didn't were considered tolerant. So the EAT diet consisted of 6 foods. Cow's milk in the form of yogurt was first in all of the consumer group. And then in random assortment, they were introduced peanut, sesame in the form of tahini, whitefish, and cooked egg. And then wheat was always introduced last in all the groups due to the theoretical risk of EOE. I found the choice of foods interesting, but I guess this is the food prevalence in England. And so the infants had to, in the consumption group, ate 2 grams of each of these foods twice a week. So again, from Gideon's talk here, this is kind of a scheduling of all the foods with yogurt and peanut butter, and then egg and yogurt, and then fish, bread that they had to consume. So here is the intention to treat data from this. So if you look at the prevalence of allergy, over here is on the y-axis, and then the standard introduction group versus the early introduction group. There was not a statistically significant difference between the two. It was 20%, but there was no statistical difference between the two. But if you took the data and used per protocol analysis, one of the problems that Gideon was having with this cohort was compliance. To be quite frank, a lot of the food that he was giving to these kids were cooked in a standardized fashion, and not all kids eat the same or tolerate the same, so a lot of them did not want to eat that. So there was quite a few of the kids that did not. So if you look at the total numbers here, the intention to treat is 1,100, while the per protocol is only 732. But if you look at this data, it is statistically significant with a 67% decrease in prevalence to any of the 6 food allergies, so any of them. Here's his data on peanuts. You could see here, again with the per protocol analysis, there was a 100% decrease in peanut allergy compared in the early introduction group versus the standard introduction group. And then the similar type of thing for egg, where you saw a statistically significant difference. But again, in the intention to treat analysis, there was no statistical difference between the 2 groups. So the intention to treat analysis, as I mentioned, did not reveal a statistically significant difference. But the patients who did follow the per protocol analysis, there was a significant difference of 67% reduction in food allergy. And in the egg group, if they followed the protocol, 75% reduction, and then 100% reduction in peanut allergy. And as I mentioned, adherence was a challenge, and they were so the groups that were not compliant had very similar outcomes to the group that just had the standard consumption. One of the questions that came up during this talk was, could excessive amounts, because yes, you gave guidelines of like minimal amounts, but what happens if they ate 10 grams, 12 grams of this, and they went to town on it? Did that increase their risk of food allergy? And they looked at that where kids had an increased amount, and they did not see a statistical increase in food allergy in that group as well. So there seemed to be minimums, but not maximums for this. That's all I got for this.
So looks like egg and peanut early introduction seems to be beneficial, but the other food not so much.
Not as stark, but yeah.
Do you know if they're doing a similar study in at-risk kids?
For this?
Yeah, it was interesting that, the LEAP study was particularly selecting out at-risk children. Here they generalized it to the general population. When the LEAP study was done, I sort of naively assumed that in at-risk kids, early introduction and persistent feeding would be beneficial for all allergenic foods. They haven't tested that question.
Not as such yet, no. I assume that they're going to extrapolate out for these at risk. I mean, it was all comers. They didn't exclude them from the study either.
So I'm going to be talking about two talks. The first one was, here's a disclosure slide. It shouldn't have any impact on what I'm talking about today. The first one was one that Dick Weber from National Jewish and I headed on Saturday morning. And the second one will be one with much more distinguished faculty than myself, one of the big Hugh Sampson, Mimi Tang, and a Nowak. And so the first one, let's see. If you recall, this title looks familiar, The Legalization of Cannabis and the Implications for the Allergy Care Provider. It's because I presented something similar to this in Journal Club last year, but some new information. So I'll just highlight a few of these slides briefly. So this is the current marijuana legalization status in the United States, with recreational cannabis use being legalized in Washington, Oregon, Colorado, Alaska, and also in Washington, D.C. This slide I find interesting and was results from the most recent results that are out from the National Youth Risk Behavior Survey. I wanted to highlight current marijuana use in adolescents, and that's about 23.4%, versus current cigarette use, which is 15.7%. And as far as ever used marijuana, teenagers 9 to 12th grade reported 40% or so reported that ever used marijuana versus 41% for cigarettes. I just found this information interesting, and I think once, one of my interests is in adolescents with asthma, and also how our teenagers perceive marijuana and cannabis, and in light of recent legalization. And we found that as perception of harm goes down, use goes up. A lot of adults and teens will think now that it's being legalized or being used for medication purposes, that marijuana is probably not harmful. So I think in recent years we've seen rates of abuse go up, particularly in our state, where marijuana use has more than doubled the rate of cigarette use. This was from the 2014 Washington State Healthy Youth Survey. And another concern is these e-cigarettes and vaping mechanisms, where some folks don't really say that they smoke, so you have to ask whether they're vaping. So I think it's an important take-home for some of us when we're asking our patients whether they smoke tobacco, or I think it's important to not only ask about smoking, but ask about vaping. They might think of those two things as being very different. Why is it such a big deal? We know from a respiratory standpoint, smoking marijuana can clearly cause symptoms of chronic bronchitis. But when started in adolescence and done regularly, marijuana use regularly can be much more associated with addiction, all the brain development, poor educational outcomes, and cognitive impairment. So it's a really important thing, I think, to find out and to intervene early if possible. You'd think that our teenagers with asthma wouldn't smoke marijuana or use inhalants. However, one study looking at the 2003 National Youth Risk Behavior Survey looked at high school students with current asthma, and that they use cigarettes, cigars, marijuana, and inhalants at rates equal to or greater than high school students without current asthma. The American Academy of Pediatrics recently had some position statements about marijuana, and this was one article out of Contemporary Pediatrics where one of the authors talked about the perceptions of cannabis and in many adults and kids that it's medicine, and they really have this stance where to say that marijuana is not a medicine. And I would have to agree. You have to realize that marijuana itself has more than 400 to 600 compounds in it, over 40 to 60 cannabinoids in there, and each of those cannabinoids can have some potential therapeutic benefit. So right now, the FDA has approved Marinol, synthetic THC, as well as Sativex, which is a THC cannabidiol formulation for treatment of certain things. So we have to realize that a lot of these folks will see John smoking marijuana to help with his headaches or to help with sleep. We have to realize that when you smoke the whole plant, you're getting a bunch of other things in there as well. This was an interesting slide, and we know that people smoke marijuana, ingest it, vape it, as we mentioned, but there's something called dabbing, which I haven't heard of. Have you guys ever heard of this? Anyone? Yeah, so it's apparently a new way of inhaling an extremely potent form of THC, and they use it they do this by extracting THC from cannabis through using a process of butane gas. I don't know exactly how it's done, but it's a new thing that a lot of the folks have been using to isolate THC in a higher concentration.
House has been exploding in Denver because of this.
Really?
Yeah.
He said house is exploding in Denver because of this. Yeah, so when you look at the THC concentration of marijuana now, the way it used to be, let's say back in the 60s and 70s, it's several-fold higher than what it used to be, up to 10 times higher. So it's important to note, there's a lot of folks who end up in the emergency room, even adults who, let's say, smoke in college, then they'll take a hit with their kid's weed and end up in the emergency room because they're having a psychotic episode. So it's important to keep that in mind. We know from a respiratory standpoint, interestingly enough, and I didn't know this a few years ago, that marijuana can cause bronchodilation immediately, and that's largely due to the THC content of marijuana. However, when you're combusting it, you're getting a lot of, it can have a lot of deleterious effects, or negative effects, those of them being respiratory symptoms such as cough and sputum production. We can clearly see bronchomucosal abnormalities with regular use of marijuana, and reduced function of alveolar macrophages, the long-term effect of which is yet to be determined. And there's some questionable effects, such as spontaneous pneumothoraces, which could be due to the fact that when marijuana is inhaled, you take in a huge deep breath, hold your breath, so it could be due to that. But there have been case reports of that. There's been case reports of infection, namely aspergillus infections. They've found many samples of marijuana to be contaminated not only with aspergillus but penicillium, and so a lot of these case reports have been described in immunocompromised patients. So if you're prescribing something to a cancer patient, I think it's very important to keep in mind that is a potential thing to worry about, is risk of infection, especially if they're immunocompromised. And there's no known risk of COPD, and there is an unclear risk of cancer. And I think, once longer-term studies are done, there'll be a little bit more data out there in the next few years, hopefully. And so allergy to cannabis has been described. Have you guys tested, by the way, to marijuana in your offices? Anyone? I've done it once or twice.
How do you do it?
Well, they just bring it in. And so the way to do it, the point of this is there's no standardized approach, right? There's no actual extract. So you pretty much use the buds and the flowers and macerate it, and the patient will bring it in. The one patient that I had, one of the two patients that I had, he had intermittent urticaria and symptoms of rhinitis, and was a marijuana grower himself. Grows it legally. Whenever he brushed up against his plants, he'd get some hives. And for what it's worth, was skin test positive. Now, I didn't skin test myself or my staff because you want to check for an irritant reaction. That probably would have been a good thing to do. But for what it's worth, he was positive with a negative saline and a positive histamine. And so there have been cases of allergic sensitization to cannabis reported. A lot of them can include nasal congestion, rhinitis, pharyngitis, wheezing, etc. This is mainly from either smoking it or touching it or ingesting it. Some of the reports of anaphylaxis from marijuana have been reported mostly from ingestion, from what I recall. So I think that's important to keep in mind. It's also important to keep in mind that in certain parts of the world, in certain parts of the country, marijuana grows naturally outside and can be a potential pollinator. So like other weeds, it does pollinate in the late fall or in the late summer and fall, and can cause just classic symptoms of allergic rhinitis. And the particle size of the pollen of marijuana is actually relatively small, and it does cross-react with other things like nettle, I believe. There's a lot of cross-reactivity with certain foods like tomato, etc. And there's a good article out of the Annals. It was a Ocampo, I believe, article reviewed cannabis as the unconventional weed allergen. So I think it's a good paper to bring up. And it talks about cannabis allergy, and I think it's a good thing to read about. Because I think, in our state particularly, we should be aware of it. And we should really ask our patients about marijuana smoking, vaping, etc. And with our teen patients, if we have some rapport with them and their family, I think it's important to speak to our teenage patients by themselves at some point, which would be good practice, because they're probably not going to be able to tell you all the things that they do when their parents are in the room. You'll be able to get more information about smoking and marijuana use when it's outside the room. So the next...
How old do you have to be to buy it legally?
That's a good question. Is it 18 or 21?
It's 21.
21. Okay. So the next talk I want to talk about, we have a few minutes left here. I'm going to skip over the first few slides because I don't want to be redundant with what Dan talked about. This wasn't really a energized pro-con debate. I think both speakers pretty much agreed on what to do. So we're going to skip through some of these things because this summarizes the LEAP study. And I want to get to this slide. So actually, before this, let's back up a little bit. So in 2016, this year, the National Institutes of Allergy and Infectious Disease wrote an addendum to the 2010 guidelines for diagnosis and management of food allergy. So they pretty much echoed some of what the LEAP data brought about, but they said, look, if you're a kid with no eczema or food allergy, it's okay to introduce peanut at home without testing. They would prefer that peanut not be the first food that you introduce, just to avoid any sort of confusion, because some kids at 4 months of age just aren't able to eat any sort of solid to begin with, just because they're not developmentally ready. But if they said, okay, to introduce peanut at home, with mild to moderate eczema, not severe eczema, but mild to moderate eczema, their stance, this expert panel's stance was that they were okay with introducing peanut at home. However, they understood that in-office evaluation and oral food challenge may be necessary, depending on the comfort of the physician and the family. The problem here, I think, is how do you classify eczema? Right? I mean, if you have a kid, how do you know whether it's moderate or severe? And I think that's one of the conundrums, is to find out. You could do a SCORAD, right, which we do for clinical research purposes, but in clinical practice, I don't usually use a SCORAD. So, there's different definitions of severe eczema, and I think, if you have a kid with a significant amount of eczema, I think it's hard to know, is this moderate or severe? So that's one thing to think about. The other thing is skin prick test reagents and testing devices and methodology do vary among practitioners, so we need to keep that in mind. And they also cite information from the Health Nut study, which was Peters and colleagues here in this last bullet point, where they talk about, in this study where physicians conducted oral food challenges in infants with greater than 3 millimeter skin prick tests, should be aware that the probability of a positive challenge increases with wheal size in children 12 to 14 months of age. This was a study out of Australia that looked at older children and introduction of peanut in older children, and found even then in those cases the severity of reactions in those children were relatively mild. So this new addendum, 2016 addendum, suggested this route when you find an infant with severe eczema and or egg allergy, that you could do one of two things. So Hugh Sampson was really kind of talking about this data and pushing that for skin prick testing prior to introduction. However, he and Mimi Tang also both agree that, look, when it comes to seeing every child with severe eczema, is there enough manpower in the allergy workforce to do this? I don't think we've seen a flooding of that in our practices, because I think pediatricians are still uncomfortable with knowing how to deal with this. So I think the word is still trickling down, and the word is getting out about this new information. But that Dr. Tang, Mimi Tang from Australia, recommended that look, a pediatrician could potentially see this patient at 4 months of age. If they have severe eczema or a history consistent with egg allergy, they could do a blood test just to peanut and nothing else because of the poor predictive value of other tests. And because there's relatively good negative predictive value, particularly for peanut, that in these cases they could tell the infant to go ahead and either introduce peanut at home if the blood test is negative, or if necessary, do a supervised feeding in the office. I would be okay with that. I think the argument would be that, look, if every kid needed to see an allergist, there could be a 1 or 2 month delay in seeing the allergist, and so that could potentially reduce that child's chances of tolerating peanut. So earlier the better. Now, if the child has a positive blood test, then they're sent to the allergist where skin testing can be done. If we recall from the LEAP study, they randomized patients with negative skin testing as well as patients with positive skin testing. And by definition in the LEAP study, the positive skin test was defined as 1 millimeter to 4 millimeters. And anyone above 4 millimeters was excluded because they were already deemed as being sensitized and allergic to peanut. However, based on some prior information and some information from the Health Nut study out of Australia, the new NIAID guidelines suggest to do this: 0 to 2 millimeters skin test to either introduce at home, and that would be 2 grams of peanut, or do a supervised feeding in the office based on physician-parental preference. 3 to 7 millimeters would buy you an oral food challenge in the office. 8 millimeters or above would send you home to not eat peanut at all. So this is new information, and I think we need to be careful about classifying eczema and also reading skin test results. And I wanted to see if anyone else had any thoughts or comments about this. If you had a kid with a 7 millimeter skin test who's 4 or 5 months of age in your office with severe eczema, are you going to challenge him in your office? Or is that a patient that we'd send to the Seattle Food Challenge?
Yeah. We don't challenge babies.
What's that?
We don't challenge babies.
Oh, they don't. So I thought they were doing that.
No.
We were doing that. Okay. So would we do that in our offices? I would be a little weary. I might skin test again because I know from the LEAP study they actually did 2 skin tests. We got the median versus the average. So that's new information. That was new information for me anyway. And these are just 2 slides that kind of echoed what I just said verbally.
So what are you telling these families? You're telling them that you prefer not to give them any, they shouldn't probably have any,
So if their skin tests are large enough, I'll just say, look, you're already sensitized to peanut, and they just avoid peanuts. But up until a few months ago, that was really what I was doing. And 4 millimeters was my cutoff. And if it was from 1 to 4 millimeters, I would challenge them in the office. If they were skin test negative, they'd just go home. Right? But with these new guidelines, they're kind of pushing the envelope a little bit with the size of the skin test. But I think there's variability. I think if you use a bifurcated needle versus not, right? What kind of extract you use. So I think some element of caution would be appropriate.
Do you use specific IgE?
I don't use specific IgE. I think because we have, as we all know, we have skin testing very, very available to us. To poke a kid can be a little bit more, bit more of an intervention. But look, if you're in a certain part of Idaho or deep in eastern Washington and there's no allergist around, you're going to wait 2 months to see an allergist, I would encourage the pediatrician to get food-specific IgE just to peanut. And if the IgE is negative, that can eat that peanut at home. That would be my recommendation, and that's the current recommendation.
If the mother is allergic, could these be maternal antibodies?
Yeah, that's a good question. So the question is, if the mom's allergic, could that be maternal antibodies?
Yeah. Yes. If I need to call them.
Yeah. And you could certainly get that history.
I just check. Yeah,
Would you get total IgE with that too?
Yeah, that's the question. The question is, would you get total IgE with that too? I probably would, because if that total IgE is elevated and you have a completely negative IgE for peanut, that would make me feel much more comfortable. So a total IgE is not unreasonable. I think the other pitfall is the parent will say, well, can you throw in egg and wheat and soy and all these other foods into that? That's when this can become a problem. So then you get this kid who's sensitized to multiple things, then what do you do about the elevated IgE to all these other foods? So I think if you had a pediatrician who's asking you, can I get a blood test of peanuts specifically, I think that's very reasonable to do. Because, again, waiting for a referral to do a skin test sometimes in some cases can take a while.
And David makes a good point. You just found a site that IgE from mom is actually found in cord blood. So it's found in babies. So if this is done in a less than 6-month-old,
Yeah.
you can't trust those numbers.
Now that's if mom has allergy to
Sure.
peanut.
But are you going to blood test mom and baby? I mean, that's a whole lot of logistical.
Right. It's become the hard thing to
That'd be-
translate to a pediatric office.
And you said one thing I'm just curious about. They in the EAT study, they introduced wheat last.
Yeah.
I thought it was because of concern of celiac disease, not EOE.
Oh, sorry, celiac.
You said EOE, but it was celiac.
Yeah, for zoonosis. That was I was going to ask you about that.
Sorry about
You know,
that.
the other thing, I don't know, I don't see enough young children that don't deal with food allergy that much, but all of this work is, the leading clinical stuff going on in our field, but it doesn't seem like the pediatric world is listening.
Yeah.
In what
Right.
way? You're still recommending avoiding these foods? or-
I don't
They-
think pediatricians are changing their behavior.
I gave a talk to a bunch of a group of pediatricians talking exactly about this. There was a lot of trepidation about this.
Yeah.
They were like, I can just see my family is just giving them enchiladas or something, like just giving them regular food when they're like 4-month-old and kids choking is what they're scared of, and so they just don't want to tell them don't eat.
I think it's going to take time, and
Yeah.
I think it's up to us too. I mean, you can't just get this information by osmosis,
It's
right?
20-30 years of ingrained training, so it's going to take a long time.
Right, and I think it's important for us to get on the community and talk about this a little bit, and at least talk about some of the basic guidelines, so at least they can think about it, so that when they see a kid with moderate